Right. So in part two, we started with talking about hormone disorders throughout the lifespan. And with hormone disorders throughout the lifespan, one of the things you want to remember is just the onset of these things. Puberty onset is usually 10 to 13. Menarche is like 12 to 14. Average age is 13. Any kind of variations there, you might want to suspect things like obesity or different types of endocrine disrupting chemicals or imbalanced microbiomes or impaired biotransformation. And then as women get into ages 45, 50, average 45 to 55, they start going to perimenopause. It may be as short as 3 months. It may be as long as 10 years. The average length of time for perimenopause is 3 to 4 years. Average age is 50. And perimenopause is strongly dependent upon, perimenopause transition is really dependent upon how healthy a person's resilience is to ups and downs of their FSH and LH. Adrenal gland function is critical for that. And then eventually they get into menopause. Menopause onset age 50 to 58, average age is 51. And once they get into menopause, if their hormone levels are deficient, they'll have increased risk for cognitive decline, Alzheimer's disease, bone density loss, osteoporosis. There's always the risk for cancer development with high or low hormones, variations of cancers. And then, you're worried about cardiovascular, heart attack, strokes, and those conditions as well. So we also talked about female menstruating disorders, like with PMS and premenstrual disorders and migraines and postmenstrual syndromes. And then we talked about patients that have different type of menstrual irregularities. With like PMS and PMDD and menstrual migraines, it's really like typically for most women, it's a combination of blood sugar imbalances, prostaglandin imbalances, unhealthy microbiomes, unhealthy diet and lifestyle. Like once you resolve those things, you really get a big change. The biggest one is to really look at the fats and prostaglandin imbalances as a major factor. And, it may take 1 cycle, 2 cycle, 3 cycles to make some changes to notice a difference. And that's sometimes what's a little bit frustrating with the patient, but it's really the only way to really make some changes and difference there. With postmenopausal syndrome, the key thing that people are assuming this may be related to is just depletion of electrolytes, depletion of things like potassium, sodium, that they just fall apart afterwards, like adrenal exhaustion related to those patterns. And sometimes like taking adrenal glandulars or adrenal adaptogen supports, some electrolytes after the menstrual cycle can really make them function a lot better right away. So those are things you may want to consider. And then we had these menstrual cycle irregularities. And for each of these menstrual cycle irregularities, we went over underlying mechanisms that are involved. The best functional medicine approaches are the ones that identify mechanisms immediately from the clinical workup and can address them right away. The worst functional medicine practitioners are the ones that just try to supplement their way out of stuff and not really understand mechanisms, and they're constantly looking for protocols. And as someone who's taught functional medicine for a long time, I could immediately tell at the end of a seminar who I was talking to afterwards. The ones that came up and were looking for, like, what do I do? What's my protocol? I'm like, this is not, in my head, I would think this is not for you. And then the ones that were talking to me about, like, well, how do I really find, like, this laboratory change? What lab should I really, I can see they were really trying to figure out how to do the undefined mechanism. Those are always the best practitioners. And I can tell you over the 25 years of teaching functional medicine all over the country and all throughout Europe, the ones that get it have a lot of clinical success, and they have no problems with their practice in patients. The ones that try to shortcut, the ones that try to jump to protocols, the ones that want to just jump into hormone replacement therapy because you get immediately a hero and have some kind of effect, are the ones that fail in practice. And they keep thinking it's like the world. It's not the world. It's your skill level. Your skill level makes the difference. You have to know how to pick up, identify these patterns. You got to look at labs. You got to do these follow-ups. Those are the main things that you have to really think about and focus about. Now, all these menstrual irregularities, you have to rule out hypothyroidism. You have to rule out PCOS. Hypothyroidism, what you're really looking for is the hypothyroid patterns. If their TSH levels are high, you have to start there. Sometimes conversion issues, T4 to T3 can be a factor, but really you're looking for those hypothyroid patterns. PCOS is really, really common. PCOS is not always easy to find, and let me tell you a few things about PCOS just as a recap. If you see elevated testosterone any given time with any kind of labs, like the case study I showed you, just immediately suspect PCOS, okay? And that can throw off and any other hormone imbalance you see, like abnormal FSH, LH, abnormal estradiol peaks, abnormal progesterone outputs, luteal phase, follicular phase deficits. They can all be caused when a person has PCOS. Okay, because the androgen just throw off the FSH, LH pathways so aggressively. There's going to be people that have PCOS that won't be diagnosed. First of all, there'll be those that go in and get a workup by their OBGYN. They do an ultrasound, and they go, we don't see any signs of polycystic ovarian syndrome, so the person doesn't have it. And you're looking at your lab test going, I don't really give a, crap, because their testosterone's off the chart. Like, ultrasound's not 100% reliable. It's not going to catch all of it. Some of these cystic changes are going to be very subtle, but the metabolic going to be very, very active. So be aware that there's going to be patients that have clearly lab testing PCOS, and an ultrasound it's not going to show. Still treat them as if they have PCOS. And then there's going to be another group of patients that are going to get overlooked in the healthcare system with PCOS, which will be the underweight PCOS patients that are really having this hypoglycemia, insulin resistance surge. They're not going to get assessed in the healthcare system. You still have to treat them for things like for PCOS. And PCOS is really aggressive. The more body fat they have, the longer it's been going on, the harder it is to unwind. Ideally, as soon as you start putting them on insulin sensitizing compounds like berberine, or even if they take things like metformin, but berberine, metformin, fish oils, essential fatty acids, myo-inositol, alpha-lipoic acid, the better. Diversifying their microbiome, especially things like butyrate, short-chain fatty acids, are really, really critical. Time-restricted feeding, intermittent fasting, movement, exercise, things that can burn off insulin can be really important. But then for some people, you have to go deeper, and you may have to use things like peptides, like GLP-1 peptides and the human growth hormone peptides, and in combination with all those other things, and even ketogenic diets to really break them out of the pattern. So it can get really aggressive and ugly at times, but you got to go down that path when it's there. And that's sometimes it's the only way out. You see chronic patients that have gone from one practitioner to the next, and they can't get the patient out because they haven't gone deep and aggressive enough with them. Okay. It's perimenopause. This is where many women have their health compromised and they don't really recover. Now, as women go into perimenopause, most people have some degree of underlying inflammatory conditions. They can all be made worse in that perimenopausal transition. This will be shocking to the patient. They'll be really confused. They will say things like, oh, I was so healthy. I don't know what happened to me. I don't know what I did wrong. And they may have not done anything wrong. It's just they had this severe immune inflammatory reaction that took place when their estrogen levels dropped. And one of the things we talked about is making sure they have healthy adrenal glands before or as they transition into menopause, in that perimenopausal state, so they don't have that big drop that can then trigger the whole immunological cascade that puts fire in everything. Now, once fire is added in everything, and get to perimenopause and actually have their menstrual cycle gone for a year and they're truly in menopause, that's when you really have to be on the lookout for Alzheimer's disease, cardiovascular disease. Make sure they get the bone density testing done. You got to make sure that they maintain their muscle mass. Muscle mass maintenance, especially as you get older, is so critical for health outcomes and the ability to release these myokines to support the brain, support the heart, and just to be able to actually have healthy activities of daily living. It is extremely difficult to build muscle as you get older. So you want to have as much bone density, as much muscle mass as you get into your senior years, okay? And then we talked about andropause. We went through all the different patterns with andropause. We went over the lab patterns. This is really thorough summary chart of all the things you would see with that as well. And then we went into the clinical evaluation. And with the clinical evaluation, we went over this chart. And with this chart, we talked about from general symptoms to dietary evaluation and lifestyle and physical exam, routine blood work, and toxicology profiles, and the adrenal salivary index. And those are pretty routine to do with anyone with, whether they have menstrual cycle disorder or perimenopause or andropause. You want to go through those same steps. Then we talked about specific things you might want to do for each one of those conditions themselves, based on which hormone profiles you want to run. But starting with the metabolic assessment form, maybe doing standardized questionnaire forms with males, checking adrenal function. These are great places to start, especially as you're waiting for some of these lab tests to come in. And then we went into part 2, which was treatment. And then for the treatment section, we said, the key thing with experienced practitioners is, first of all, they don't treat everything at once. The main clinical difference I've seen over the years with really good functional medicine practitioners is they prioritize which pathways they're going to treat to have the effect on as many systems as possible. Okay? Inexperienced people think more is better, and they overload the patient with too many things to do all at once, hoping something will work, like a shotgun approach. Shotgun approaches exhaust patients. Shotgun approaches deplete patient funds, and they lose patient trust. You want to be precise in your approach. So you want to look at things like the metabolic assessment form. You want to kind of figure out what things are. You want to connect this with the patient and say, listen, you have a lot of hypoglycemia symptoms. Hypoglycemia symptoms could be one of the reasons why you're having such a hard time with your menstrual cycles. It's going to impact your adrenal glands. We got to get rid of these symptoms, and you circle it. The way we're going to get rid of these symptoms is you give him a piece of paper. Here's how you stabilize the blood sugar. And all of a sudden, the sheet you gave him or some supplement recommendation you gave him now have a personal association with the symptoms they have clearly marked off in the questionnaire form, and they can make that connection. That becomes very powerful. So one of the skills of treatment isn't what treatment you also give a patient, but how you connect their symptoms and what you need to do and where they need to go. That's clear for them. Randomly, like the model of like having your patient understand and like, you're so smart, you're the doctor, you're the healthcare practitioner, you know everything, they just need to listen to you. Like that doesn't work, because with functional medicine, you need a highly compliant patient. And most practitioners that seek out functional medicine practitioners are intelligent and have already spent a lot of time focusing on their health and have read up on a lot of things, and they're critical thinkers. So you really have to make sure you can connect with them. And I can't tell you how many times I've heard patients come in and go, yeah, I went to go see this person, and they'll say stuff like, the guy was a total idiot. Like they feel that way. They're not going to say that to practitioners like that. But if you don't have the ability to connect and explain everything to them, and especially if they read up on stuff, you could have the problem with the functional medicine patient population that's out there. Now, this is another sheet we talked about with lifestyle approaches. This is just a summary how to quickly look at the dietary recommendations, lifestyle recommendations, and actually do some realistic things to reduce endocrine disrupting chemical load for yourself or for your patients. And then we talked about HRT. HRT, obviously, we like the basic customized approach model where someone gets their hormones checked and then works with a physician and a compounding pharmacist to get specific dosages to them. But that's not going to fix many things by itself either. It's going to be very supportive and helpful for a lot of people. But there's lots of conditions where, in addition to doing that, they're going to need to support their microbiome and support the detoxification pathways and support the prostaglandins and keep their blood sugar stable and stop their insulin spikes in order to have really an effect. And then there's also many patients that they're not even candidates for HRT. Okay. And then here's, then I give you, the simple protocols for each of the different conditions. With puberty, for example, really focus on fatty acids, body mass index, rule out medications. With PMS, prostaglandins, blood sugar stability, adrenal support, amenorrhea, you got to make sure they have enough caloric intake. Look at their protein intake, look at their fat intake. It give you the calculations you can do to help them understand what's going on. Their body weight times 15 is the total calories. 1 gram of protein for each pound of body weight is the protein intake, and at least 30% of the calories from body fat. So once you know what their total calories by their body weight, you just do 30% of that, and you can figure out what their fat calories are. This is the minimum requirement to have the precursors for endocrine function. Anything like malabsorption or blood sugar levels that are low can cause amenorrhea. Metabolic overtraining syndrome can cause this. Cholesterol levels that get too low can also cause that. And then we had charts for each of these other conditions as well. And then as we went into andropause and menopause, we're really looking at just slowing down disease processes that have increased risk for progressing when hormone levels are low. So hopefully keeping hormone levels at a normal reference range, whether with lifestyle and diet or with replacement, but still constantly looking at brain health, bone health, cardiovascular health, and the potential for any kind of master tumors were really the focus of the treatment approach, evaluation approach. Okay, so those are the main things from part 2. Let's go into some questions we had. Okay, let's go into this. We see patients successfully losing weight using semaglutide or trispeptide. However, it causes menstrual irregularities in some and the return of menses for some women in menopause. Do you know the mechanism for this? Well, this does happen with some patients, and these peptides sometimes have far-reaching effects than what we know. Like some people shouldn't be on these. These are being overutilized. I'm not a big proponent of these peptides being used for that unless they have severe PCOS or severe insulin issues that are a factor. But they're sometimes completely disrupting their body fat. There's sometimes body fat's dropping so low that can throw off their hypothalamus pituitary feedback. If anything, remember that body fat is part of the endocrine system. That body fat is constantly releasing a whole spectrum of adaptokines that are really modulating the hypothalamic pituitary axis. And if you get sudden changes in those things, it makes sense that they can really throw off the menstrual cycle system. So it does happen, and it's just something to be aware of. Okay. Next question. Can taking isoflavones make HRT more effective in women? Could that be negative for women on oral contraceptives? So this is up for debate. No one really knows. No one's ever really done the study or even know how you even design a study to measure this effectively, because the effect size would be so minimal you wouldn't be able to see any kind of statistically significant change, I would guess. But lots of people take isoflavones and HRT together to have a protective effect. Some people take it and they feel like it's getting in the way of their HRT, and it's just a subjective feeling they have, which might be very real to them. And then some people just feel better just taking some flavonoids with it. Some people are doing both. They don't even know that they may counteract each other, and they're just doing a combination of things. But I've never seen really any major problems with it. The biggest concern with isoflavones, so-called phytoestrogens, selective estrogen receptor modulators with men, is they worry that if men take these or men have soy products, their testosterone levels are going to plummet and estrogen levels are going to be high. And we went over a pretty good meta-analysis of 40-something plus studies, I think it was, that showed that it doesn't have any of those negative effects. So it's not really a big concern. As far as oral contraceptives go, it's not going to have any effects on oral contraception, because the synthetic estrogen and progestins that are in there are still going to suppress FSH and LH, unrelated to what's happening with the SCRM at the receptor site. So there's going to be no change in the contraception part of it if someone's taking SCRMs. Okay, next question. Why do some women respond poorly to progesterone cream? This is the uniqueness of hormones too. When you talk to practitioners that do a lot of different types of hormone replacement therapy, they may have a preference, but they also realize some patients do better with one form versus another. I'm not a big fan of the topicals as a personal bias, just because I've seen them cause so much overload in people. Typically with topical creams like progesterone, they were heavily used for a long period of time since they were over the counter, and people were just going in there and getting it. And then there's a guy named John Lee who wrote a book that became a bestseller, and everyone should be on progesterone. It's the best thing and safest thing ever. And everyone was just rubbing progesterone cream all over themselves. And when you check their profiles, they were really, really high. And remember, over a period of time, especially with topical cream delivery, the progesterone is a steroid hormone. It can easily store in body fat. So when they rub the cream on, some of that hormone cream goes into their body fat, and then they start to get buildup in their body fat. And over a period of time, they get really, really high levels. And even when they stop, their levels like progesterone, let's say the range was 800 as a high end, they're over 2,000. The lab says can't measure anymore. It's too saturated. And then they're off the cream for 6 months. They repeat, it's still over 2,000. It's just stored in the body. We're this is not right. This is too much. This is just over-the-counter progesterone cream. So I think with a lot of people has the ability to store up in their system, and it's very easy to overload people with topical cream. Remember, topical creams have to be in a free fraction form to get into the system. So when you bombard, remember, free fraction forms are like 1% to 2%. So when you bombard someone with high amounts of progesterone in free fraction form that can also store in body fat over a period of time, very short period of time, you can definitely cause all types of imbalances. Okay, next question. A patient said her previous doctor wanted to take her off HRT while she was on a weight loss diet because she would get the hormones she needed from estrogen released from fat stores. Is there any merit to this? Would the estrogen be in an appropriate form for the body to use, or will it have been metabolized to some degree? I don't know. It's anything when you look like what practitioners are doing, they all have like a working model. And, my thought has always been, if you're working with a practitioner and that's a working model and you feel like you're comfortable with them, let them work through their working model and see what happens. You don't want to have lots of different working models all at the same time. And also, I've also learned as a practitioner, when I'm working with patients from a functional medicine perspective, at least, I don't want 2 or 3 other functional medicine practitioners on board with different models because it throws everything off, okay? Now, if you lose body fat, you're definitely going to release some stored hormones into your system, but how would you know how much and to what degree, if that's going to be normal? And then also, you're also going to have a lot of toxins and chemicals and endocrine disrupting chemicals released into your system. Now, when people lose bone, most noticeable thing that's been shown in the literature is lead levels go up. So heavy metals and lead tend to store in bones. So when people get osteoporosis, they get very high lead levels. And as they're losing bone, their lead levels go up, that's stored in bone. But when people have weight loss and lose fat, they can definitely have endocrine disrupting chemicals and pesticides and other hormones in their system being released. And there's also some theories in the literature of that's why some people weight gain, they call them obesogens, because it's the way the body traps toxins so it doesn't go into the organ system. So it builds fat cells and surrounds them to stop the toxins from getting into the organ system, vital tissue. And that's one of the theories of obesogens. So the question is how much hormones are released and all that. It's hard to say. I don't know. But this is the thing with healthcare. You have working theories, you go through it, and you see how things are. Obviously, they can measure hormones if they wanted to and see where they are. Okay. I'm seeing estriol become more popular as a face cream. Yeah. Is this from form of estrogen potent enough to cause imbalances if used topically? Absolutely. So, estradiol is the strongest estrogen. Estriol being E3, triol, E3, is the weakest form of estrogen, but it's still a powerful estrogen. And if someone's using this as a face cream, it's going to have a local effect of making their skin look good, but it's going to increase estrogens in their body, all throughout their body. And whether that's appropriate for that person is going to be something that unique to that person itself. But it's definitely going to cause estrogen elevation in the system, and estrogen is still no joke. What sort of health impacts should adults wanting to transition genders be aware of in terms of hormone therapy? What about children and adolescents? I have no idea. No clinical experience. I have not read anything in the literature about this. I have no qualification or background to answer this question. Let's go on. In a non-adapted stress response, you show that cortisol goes down, but epinephrine norepinephrine goes up. That explains why people with adrenal fatigue still easily can't sleep through the night or are sensitive to light and sound. How can they build resiliency to avoid triggering these hormones so easily? I guess with a non-adaptive stress response is meaning someone gets a stressor and their body has a physiological stress response against it. Everyone has some degree of tolerance of how much stress they can handle. But if it exceeds their person's adaptation to stress, and the stress response takes place, within the first few minutes, the adrenal medulla kicks in. It's epinephrine, norepinephrine, always. And then once epinephrine, norepinephrine levels go up, within the first 2 minutes, you start to have changes in cortisol. So for some people, the cortisol is already low. It can spike up a little bit higher at that point, but it's not much of a change. For other people, the cortisol is high and then stays high for many, many hours. But the epinephrine, norepinephrine going up is what actually activates the areas of the brain that are involved with the sleep-wake cycle. and it causes a person to basically have that waking up sensation. So, if people have high epinephrine, norepinephrine, they can't fall asleep. If their epinephrine, norepinephrine goes up in the middle of the night because they have nocturnal hypoglycemia, they wake up in the middle of the night. Ultimately, what is the question? Is starters that can't sleep through the night, sensitive to light and sound. If you're sensitive to light and sound, like sound cancellations, headphones, getting blood sugar stable as possible, burning off catecholamines are like the only strategies I know about that help someone sleep when they have these sensitivities. And over time, just getting their non-adaptive stress response healthier by building resiliency. So whatever things can stress their system out, but doesn't totally fatigue them. Okay. Is the ideal protein intake based on current weight if a person is overweight or an ideal weight? So when you're looking at protein insufficiency, you definitely want to look at like their ideal weight. But for most people, even the ones that are like overweight, if you get them enough protein that doesn't exceed their total caloric intake, it actually has been shown to help people lose weight. So high protein diets that don't exceed caloric that aren't above caloric demands have been shown to help with weight loss. So if you want to make it very simple, just think of it as total weight. The key thing is, though, that it doesn't cause increase of total calories above their energy demands, which typically won't do that. Okay. Is lab testing the only way to know for sure how much of a fat to eat for good prostaglandin function? Well, for the specific prostaglandin essential fatty acids, the red blood cell essential fatty acid is currently the best way, the gold standard. That's really all we have available right now. And I think it's pretty accurate. Next question. Seed oils are really demonized these days, and people are always told omega-6 fatty acids are bad. That's not true. How do we help patients know what are appropriate amounts of omega-6 fatty acids, how to shop for healthy seed oils? This is not new. People need a balance of some seed oils. People need saturated fat. People need full-blown butter. People need full-blown egg yolk. They need those healthy fats to function properly. It's just a matter of they don't need the fried food, saturated oil, fast food people are eating. But I don't know how to tell patients to stop. I don't know. Either your patient trusts you and you go through things together, or they don't. But there's a lot of demonization of omega-6 fatty acids. Okay, next question. If a perimenopausal woman is low in testosterone, but testosterone cream gives her insomnia, are there other strategies to boost her levels? Which mechanisms do you pursue? Well, first of all, just because she has low testosterone, that doesn't mean that's the main mechanism for her insomnia. It's hard to say. With hormones and fluctuating levels in perimenopause, we don't know if the assumptions that testosterone is the cause or not the cause, or levels of testosterone are causing her not to sleep or not sleep, are accurate. Because you could have a person in perimenopause and they have some bad nights, and they have a bad night a couple nights because they took a random calcium product or nutritional product and they blame everything on that. It's hard to say. I'd say I would be confused and have to talk to the patient and then figure some strategy. I wouldn't have like a routine answer to give for something like that. Next question. Are men ever too low in estradiol, the way women can become low in testosterone? It's pretty rare for men to be too in estradiol unless they're taking aromatase inhibitors and overdoing it, which you see with the bodybuilding world. And the main symptoms when men are low in estradiol is severe joint pain, swelling and inflammation, and just loss of brain function. So the brain function goes down and their joints hurt a lot. Those are major clues of low estradiol. Typically, it's going to be very rare for you to do a male profile and see a male with low estradiol. It's only going to happen from like aromatase inhibitors, things like that. Can carefully timed HRT help prevent migraines triggered by hormonal fluctuations? Yes, some people have used that. Some people have used different types of HRTs to help with migraines, but it doesn't always work. And then after a period of time, the sequence is off. It varies from person to person, but some people will use things like progesterone right around mid-cycle, right before they have their symptoms, to kind of have some vasodilating effects. That's the most common one that's used. So it can vary from one person to the next. How easy or difficult is it to get evaluated for a pituitary tumor in the healthcare system for patients with stubborn hypopituitary function? It's really easy. You can actually go to most imaging centers and pay cash and just get a brain MRI, non-contrast. See if you have a pituitary tumor. Most of these radiology centers throughout different states in the country allow direct patient access. Just get a brain MRI, non-contrast, and see and they'll as a routine screen, see if it's there. You can also do serum prolactin screen, which is the one you're worried about for endocrine dysfunction, and see if you have elevated serum prolactin levels. But an MRI would be okay. And you can even just, nowadays, like we talked about, go to these centers where they do a full body MRI just to get everything screened out, and they'll already include a brain MRI, and you can screen for that. Those are typically $800, $1,000, and you get a full body screen of any masses or growth or tumors. Okay, last question. How do you know whether pancreatic alpha cell depletion is a mechanism? Typically, if you see someone who's got hypoglycemia patterns and nothing, they have ongoing hypoglycemia forever, and they're always sensitive to hypoglycemia patterns from their lifestyle, and they have been that way for 10, 20 years, that's when you're thinking of alpha cell depletion. Okay, thank you everyone for attending this course, and I hope you found some things that are useful to you and they can help your practice, and I really appreciate your attendance. Thank you.